qui nous font le plaisir, qui viennent de loin, d'Inde et d'Allemagne. Et je crois que l'Académie est toujours honorée de recevoir des orateurs étrangers et francophones peut-être ou anglophones. Ils vont nous parler en anglais, mais ce n'est pas grave. Merci en tout cas. Mais vas-y, Sylvana, tu introduis peut-être le docteur Mohit Bandari.
Oui, et je vais le faire peut-être en anglais, vu que le docteur Bandari est anglophone. Hein, il n'est pas encore francophone. It is my great pleasure.
You have to learn French.
You have to learn French, Mohit. So it is my great pleasure to introduce Dr. Mohit Bandari. Mohit is a spectacular surgeon. He's also an endoscopist. He's an innovator. He comes from Indore, India. He's the president of the ERCAT India. And together with Mohit and Christine Steer, who will be the next speaker, we created the International Society of Bariatric Endoscopy. And Mohit will talk about the flexible endoscopy, a key factor in modern surgery. Donc, le docteur Bandari va nous parler de l'endoscopie souple, une composante de la chirurgie moderne. Le docteur Bandari est chirurgien, endoscopiste, président de l'IRCAD Inde, et c'est une opérateur, je ne sais pas si vous avez eu l'occasion de voir ces vidéos, mais exceptionnelle en chirurgie, tout comme en endoscopie souple. Mohit.
Thank you very much, Silvana, and thank you, the French Academy of Surgeons, to have invited me.
Close the mic, please.
Okay, that's fine.
Yes.
Next time around, I'll be ready with my French. So my daughter is very fluent with that. Thank you very much, everybody. This is India. I work at this campus, and as Silvana already said, we just got the status of IRCAD in India, but I have my disclosure. So I'm a weight loss surgeon. I just do bariatric surgeries. And you can see that we have done close to 31,000 bariatric procedures. Now, until 15,000 procedures, I never did a single endoscopy. But then Professor Phoebe, who was my teacher, told me that as surgeon, you will need to learn endoscopy a little bit. And that's because you are just practicing bariatric surgery. And then I got introduced to Manuel Galvao Neto, who in 2013 and 14 taught me bariatric endoscopy. He still works with me. He's a visiting faculty at the institute and comes to the department. Now, why surgeons would need endoscopy, or why bariatric surgeon should learn endoscopy and sort of complement gastroenterologist and the physicians and doing their better for the disease called as obesity, because obesity as a disease is just like cancer. It's the most chronic disease of mankind. And this is something very important. I say in my disclosure that I believe in composite care for my patients who suffer from obesity. So we have something called as an obesity board, where we work together with endocrinologists, obesity physicians, bariatric surgeons, gastroenterologists, and endoscopists. And this obesity board is just like tumor board for cancer. So we discuss algorithm for treating a patient with obesity, and we do not compete with each other, but it's a very complementary approach where everything is being dealt in a algorithmic fashion to treat disease called as obesity, just like tumor board. So everything I speak upon from my experience with 31,000 odd bariatric procedure would reflect from this spirit that we need to complement each other and treat obesity. Now, as a surgeon, why do I require to learn endoscopy and put it into my practice? So let's start with preoperative treatment for a obese patient, intraoperative, postoperative, and then primary treatment for disease called as obesity with endoscopy. And then obviously the elephant in the room, the weight regain after bariatric surgery will also require endoscopy. So if we deal with the preoperative situation, we know that obesity poses the risk of gastroesophageal reflux disease, erosive esophagitis, hiatus hernia, H. pylori infection, which is endemic in my country. And obese individuals are at least 3 times more risk of developing these findings. Now, if we have these findings, and as a surgeon, if we do not do preoperative endoscopy, what we're going to miss? We're going to miss the basic approach where if you detect a hiatus hernia, both intraoperatively and preoperatively, you need to counsel your patient that probably a gastric bypass is a better approach and not a sleeve in these individuals. So that's very, very important. Here you see a case of a large hiatus hernia, and we would not do a sleeve here because it would increase the chances of reflux. Similarly, there are pathologies like gastric polyps, ulcers, and these findings, if they go undetected, they can be in the remnant of a stomach in a gastric bypass, and then they may turn into a malignancy later on, which goes undetected. So here we need that sleeve gastrectomy is now the better option. So preoperative endoscopies become must for surgeons. The H. pylori infection is endemic in my country. We have an incidence of 15 to 30%. So we need to biopsy every other patient we treat for obesity, and then only we can expose them to the risk of a sleeve or a gastric bypass. At the same time, if we have patients who have GERD or Barrett's or esophagitis, the gastric motility and gastric emptying testing is something important alongside pH manometry, which becomes essential for these patients. Now let's come to the intraoperative problem. Now, when as a surgeon, I started doing intraoperative endoscopy, we already heard Robert talking about it, that it's important to understand the staple line integrity and preventing leaks, which is very, very important. At the same time, the guidance for doing the anastomosis, we saw a paper by Nimeri, which he has shown that they could reduce the incidence of stenosis by the endoscopic guidance intraoperatively. At the same time, when we are doing a lot of these duodenal switch, it becomes important that we do intraoperative endoscopy in each and every case. Now, this is important because as you can see here, after doing stapling, we check inside and we can find bleeding from the either from the staple line or from the anastomosis. And these bleedings will not be seen exteriorly when you see on the laparoscopy. And so it is very essential for us surgeons to manage these. And as you can see, we now have tools to manage this by either applying a clip or by either suturing the laparoscopic staple line or reinforcing the line. So we do a lot of suction and irrigation, and then we check the staple line from where it bleeds. This is one of my fellows who was doing a gastric bypass, and it was continuously bleeding on intraoperative endoscopy. And we were lucky to go and apply a clip at the base of the anastomosis where there was a bleeder, and we could prevent the bleeding and catastrophe post-operatively. Because these patients, if they bleed in a large way, they can aspirate this blood and can even present with aspiration pneumonitis later on. So that's how we deal with it. Again, now coming to post-operative role for endoscopy for surgeons, we all know that gastric bypass and sleeve both have incidence of reflux, sleeve having a higher incidence of reflux than a gastric bypass. At the same time, we know that the patients have complications by bariatric surgery like leaks and fistula. And all these complications can be dealt in by endoscopy. Nowadays, we are doing a lot of banded procedures. So you can see that there are band erosions just as this. And this band erosion can even happen years after surgery. And these needs to be detected. So I would recommend that surgeons, specifically bariatric surgeons, who involve themselves into the field seriously, should learn endoscopy and should learn how to deal with these complications. Again, several different kinds of bands are being put. You see, this is a phobia ring which got eroded. And these patients, they do not present with a peritonitis, but just present with difficulty in swallowing or obstruction. And these are the band erosions or the ring erosions which happen. Banded sleeves being done in a large number across India. Surgeons need to learn endoscopy because these patients come for follow-up to surgeons and not to gastroenterologists, and we should be able to detect these problems. Again, the weight regain because of chronic gastrogastric fistula. So this is the case where a mini gastric or a one anastomosis gastric bypass were done. And then there was a large fistula with the remnant, along with the band erosion, causing not only the weight regain, but also the problems related to the band erosion like anemia. And again, these things, when we as surgeons do a lot of endoscopy in our OPDs, we get all these findings. And if we do not, the eyes will only see what the mind would know. So we need to be prepared that there is a high incidence of marginal ulcer, band erosions, and whatnot after bariatric surgery. And we need to be prepared for that. Again, sleeve strictures are a very common problem. If the patient is not vomiting, or if the patient is not in complete obstruction, does not mean that the patient's anatomy is good. You can have sleeve strictures at the incisura, which you may need to dilate. And as surgeons, we have been trained by the bariatric endoscopist to dilate our sleeve strictures. And if you are not trained, you need to refer these patients to a gastroenterologist if he can identify and do this. At the same time, this is a very common problem with sleeve gastrectomy becoming the most commonly performed procedure across the world. I get a lot of these sleeve leaks from across the country. And the only one management for the sleeve leak is to place a mega stent, which covers half of the esophagus and goes to the first part of the duodenum. And if we are not prepared how to put these mega stents in a sleeve leaks, these sleeve leaks can go unmanaged for months together with patients in septicemia, landing in clinics, and finally dying due to simple management of peritonitis by placing a completely covered stent and doing drainage, good peritoneal lavage, and putting 2 drains, one in pelvis and one close to the leak. So, as surgeons, I feel it's mandatory that we put these stents, and we learn to put these stents with Silvana. We created a course specifically for surgeons and gastroenterologists to learn how to manage the sleeve leaks in an acute, semi-acute, chronic, and several other situations. At the same time, this is interesting in India. I don't know if it's common here. The patient who have a gastric band or a banded sleeve, when they eat coconut, they can have food bolus obstruction. And we religiously in India, coconut is being given to God, and it's like something you get from the temples. So patients eat a lot of coconut and get food bolus obstruction, and they land up in emergency in surgical clinics, not only to us, but several other surgeons across the country. And then you need to remove all these coconut pieces by using a Dormia basket. So I'm trying to make all of us realize that, bariatric surgery is one thing, but to learn how to manage these complications, because all these patients with Roux-en-Y leaks or sleeve leaks going to come back to us surgeons. And then if we do not know basic endoscopy, we cannot manage advanced cases of complications. So, I'm not talking about very complex situations such like as this, where you have a very, very chronic leak and we have to place a pigtail to equate the pressure between the cavity and the gastric cavity and the cavity of the leak, or to, chronic leaks like 6 months to 7 months old. But all these complications they happen, and these patients, they suffer. I have a lot of complications I can discuss about, like marginal ulcers, Barrett's esophagus, which we do because I do endoscopy regularly for my patients. So I see these complications very frequently in my clinic. Now let's talk about primary endoscopic therapy for obesity. There's another area where surgeons need to learn endoscopy. And you have an expert known as Silvana here sitting. So she knows everything about this procedure. She has been a teacher to most of us, along with Christine, across the world to teach us endoscopic sleeve gastroplasty. And that's why surgeons learn. There's a physiology of ESG with delayed gastric emptying, and it works very well in our situation. At the same time, intragastric balloons. But me as surgeon, I learned endoscopic sleeve from Manuel because I was having a lot of weight recidivism. Almost 50% of the sleeves I was doing were coming back to our clinic with weight regain. And 50% is a huge number. And they never wanted a surgery. They always wanted an endoscopic procedure. And so we treated both gastric bypasses and our gastric sleeves with endoscopic suturing by offering the organ plasma. I'm just on my last 3 or 4 slides. So you can see this is a 1 anastomosis gastric bypass gaining a lot of weight. So we apply argon energy source to the outlet. And then this is given to give full thickness burn so that there is stricture by healing. And then, reduction of the outlet as well as reduction of the 1 anastomosis gastric bypass pouch. Why I want to demonstrate all these videos is because now you can feel that after this presentation that surgeons need to learn endoscopy, not only for preoperative problems, but also intraoperative issues and now postoperative weight regains, but not only complications. So starting from the preoperative assessment of an obese patient to intraoperative assessment of complication to postoperative management of complication to now managing weight regain after bariatric surgery, I think it's very, very important for us surgeons to learn endoscopy, unite with the gastroenterologist in treating this disease called as obesity, because it's a very, very chronic disease. It will not leave or spare a surgeon or a gastroenterologist from pre-operative situation to the post-operative situation and lifelong. So these are the problems. And so I would say that the bariatric endoscopy is an essential tool for surgeons to diagnose different kinds of diseases, managing complications, and also for long-term weight loss maintenance with endoscopy. It's a very, very indispensable and useful tool for the surgeon. Last but not the least, this is a meeting from 16 to 18 December 2024 by the new association which Silvana, Christine, and we all of us formed, known as Bariatric Endoscopy World Association. And the first World Congress is in India. You'll get to see a lot of new stuff of bariatric endoscopy there. Thank you very much.
Mohit, I think we will take question once Christine has given her presentation. On va peut-être donner la parole après, comme ça on va grouper les deux présentations.